You know, usually when we talk about a medical diagnosis with you guys, there's this underlying expectation of mechanical precision.
Right, like a brick and bone on an X-ray.
Exactly. You fall off a ladder, your arm hurts, the X-ray shows a jagged white line across the radius bone. The doctor points to it, puts a cast on it, and that's that.
It's binary, broken or not broken.
Yeah, it's clean, it's visible, and frankly, I mean, it's comforting. But
Hmm?
the second you step into the world of abdominal pain, that comforting diagnostic machine just breaks down
Oh,
completely.
completely. It's a totally different landscape.
You are looking at a landscape that is incredibly murky. I mean, if you reach down right now and press just below your right rib cage, you are pressing on a packed, dense cavity filled with dozens of organs.
It's crowded in there.
Seriously packed through the liver, the gallbladder, the pancreas, the intestines, the stomach, the right kidney. They are all stacked on top of each other.
And all capable of complaining at the exact same time.
Right. And infuriatingly, they all share the exact same overlapping nerve pathways. It is just the ultimate black box.
It really is a phenomenal anatomical puzzle. Finding the exact source of distress inside that crowded cavity requires, well, a level of clinical deduction that feels far more like forensic science than simple photography.
That makes sense. The wiring is just messy.
Exactly. The nerves in your abdomen, the visceral nerves we call them, they aren't mapped like the nerves on your fingertips.
Okay, how so?
Well, if you prick your finger, your brain knows the exact millimeter of skin that was pierced. But the internal organs evolve differently. They send these vague, generalized distress signals that can masquerade as, completely unrelated emergencies.
Which is exactly why we are stepping into the surgeon's shoes today. We are taking you on a journey to explore the high-stakes, volatile spectrum of gallstone disease.
Specifically tracking the progression from biliary colic to its incredibly dangerous cousin, acute cholecystitis.
Yes, and our entire roadmap for this deep dive is driven by an incredible framework. We're using the Advanced Online Surgery Masterclass, designed by Professor Dr. Salvaraz.
It is a phenomenal course.
It really is. It's this immersive, world-class learning resource that uses AI collaborative case simulations and incredibly rigid surgical algorithms. It really trains the next generation of surgeons.
And it forces you out of that passive textbook reading. It plunges you straight into real-time life or death decision-making.
Which is exactly what we want to do with you today. And the centerpiece of this entire diagnostic maze is the paradox of the gallbladder itself.
Yeah, this tiny, humble, pear-shaped sac just tucked underneath the right lobe of your liver.
Its only job is to act as a temporary storage unit for bile, right?
That's it. But if a tiny millimeter-wide crystal of cholesterol gets wedged into its plumbing, it triggers a cascade of physiological failures.
Failures that can cause pain so blindingly severe. I mean, patients frequently arrive at the emergency room convinced they're having a massive, fatal heart attack.
It's terrifying for the patient.
Okay, let's unpack this. Where does that journey actually begin? Because if a patient walks into the clinic clutching their upper right stomach, the list of what could be wrong with them is genuinely terrifying.
The journey begins with that exact complaint, which we call right upper quadrant pain, or RUQ pain.
RUQ pain, okay.
Yeah. And when a clinician hears that, a massive tangled web of possibilities drops down in front of them. Let's look at the gallbladder first. The baseline problem is symptomatic cholelithiasis.
Which is just the medical term for gallstones causing temporary pain.
Correct. The classic presentation is a sharp ache in the right upper quadrant that strangely radiates around the side of the body.
Like wrapping around your ribs.
Exactly. It radiates directly into the right shoulder blade or the mid-back, usually peaking after a heavy, fatty meal, and then, mysteriously vanishing a few hours later.
Right, but what if it doesn't vanish? What if the patient also has, like, a high fever and their eyes are turning yellow?
Then you are looking at an entirely different, far more lethal beast. That's acute cholangitis.
So not just a cramp anymore.
No, this isn't just a stone causing a cramp. This is a severe bacterial infection of the entire biliary tract. That specific combination, the right upper quadrant pain, high fever, and jaundice, is called Charcot's triad.
Charcot's triad. And that's bad news.
It is a massive red flag.
Yeah.
It signals that the infection is backing up into the liver and threatening to spill into the bloodstream.
Which means sepsis.
Exactly. Fatal sepsis within hours if it's not treated.
Wow. And the list of decoys just keeps going. I mean, the source mentions a patient could have acute pancreatitis where the pancreas is actively digesting itself with its own enzyme.
Which is as painful as it sounds. The pain is severe, but it usually sits a bit more central. in the epigastric region and radiate straight back like a spear.
Or, incredibly, a myocardial infarction, a literal heart attack.
That's the danger of referred pain. The heart rests right on top of the diaphragm, and the liver and gallbladder sit right below it.
So the wires literally just get crossed.
Basically, yeah. The nerve signals can easily get crossed in the spinal cord. If an older patient with high cholesterol and a history of smoking comes in with upper abdominal pain, well, a clinician has to ensure they aren't actually looking at a dying heart muscle.
There are gastrointestinal issues, too, like a peptic ulcer burning a hole in the stomach lining.
Right, where the pain predictably spikes or drops, depending on whether the stomach is full of food or running on empty.
Or a kidney infection, acute pyelonephritis, which you can spot because tapping the patient's mid-back over the kidneys causes them to jump off the exam table in agony.
It's a very dramatic physical response.
But there's one specific decoy in this masterclass that sounds almost like a string instrument. Fitzhugh-Curtis syndrome.
Oh, Fitzhugh-Curtis syndrome is one of the most bizarre and fascinating mimics in abdominal medicine.
Okay, what is it?
It's actually a rare complication of a pelvic inflammatory disease, usually caused by a sexually transmitted infection like chlamydia or gonorrhea.
Wait, really?
Yeah, the bacteria travel all the way up from the pelvis through the abdomen and attack the thin, cellophane-like capsule that wraps around the liver.
So it's not even a liver disease, it's a pelvic infection that just migrated north.
Precisely. The body's immune system tries to fight the infection, and in the process, it creates these thick bands of scar tissue.
Inside the abdomen.
Yeah. If a surgeon puts a camera inside a patient with Fitzhugh-Curtis syndrome, they will literally see long, tight bands of white scar tissue connecting the liver directly to the underside of the diaphragm.
Wow.
They look exactly like the strings of a violin. And when the patient breathes, the liver pulls on those strings.
Oh, ouch.
Yeah, causing severe right upper quadrant pain that perfectly mimics a dying gallbladder.
Wait, I have to push back here. I mean, if we have MRIs that can read brainwaves and robotic surgical arms that can peel a grape, why are we relying on this incredibly messy, subjective guessing game?
It's a fair point.
Shouldn't a doctor just put the patient in a scanner, look at the screen, and instantly know if it's gallstone, an ulcer, or like violent strings on the liver?
What's fascinating here is that high-tech imaging only tells you what the anatomy looks like at that exact second. It doesn't tell you how the anatomy is behaving.
Oh, I see.
An ultrasound might show a gallstone, but, I mean, millions of people have gallstones that never cause them a single day of pain.
So they're just asymptomatic rocks.
Right. So if you see a stone on a scan, how do you know that stone is the thing causing the agonizing pain today and not an invisible ulcer or an early heart attack?
So the scan just proves the stone exists. It doesn't prove it's guilty.
You've hit on the core mechanism of diagnosis. That is why the simple art of talking to the patient, taking a meticulous clinical history, remains the most powerful diagnostic tool on earth.
Because the story reveals the behavior.
Exactly. The timing and the radiation of the pain are the ultimate clues. If the pain reliably starts exactly 30 minutes after eating a greasy meal, radiates specifically to the right shoulder blade, and completely resolves 3 hours later, the behavior proves the guilt.
It's a very specific signature.
Yes. That specific timeline tells us a gallstone temporarily wedged itself into the exit duct, caused the muscular wall of the gallbladder to spasm in panic, which we call biliary colic, and then the stone fell back down.
And a scan just can't tell you that story.
Only the patient can.
That detective work is just incredible. But before we get into the actual AI surgical simulation, I want to back up and look at the raw mechanics of this disease.
The epidemiology.
Yeah, because the demographics in Professor Selvaraj's masterclass are staggering.
Yeah.
We are talking about 10 to 20% of the entire American population carrying these stones.
Tens of millions of people are walking around right now with little rocks in their abdomen.
And of those people, a full 1/3 will eventually cross the line into acute cholecystitis.
Right, the severe, inflammatory, organ-destroying emergency.
But looking at the risk factors, the distribution of this disease feels incredibly unequal. Who exactly is manufacturing these stones?
The medical community has long relied on a specific heuristic, often taught to medical students as the 4Fs, to describe the classic demographic profile.
The 4Fs. Okay.
Female, fat, fertile, and 40.
Okay, let's break that down because a mnemonic is just a list of whats. I want to know the whys.
Yeah.
It says fertile, which I'm assuming means a multigravida, someone who has been pregnant multiple times. Why on earth does the entirely natural process of growing a human baby force your organs to sprout rocks?
It comes down to a perfect storm of biochemistry and fluid dynamics. Let's look at bile. Bile is mostly water, bile salts, and cholesterol.
Okay.
The liver produces it, and the gallbladder stores it. Normally, the bile salts act like microscopic dish soap, forming little spheres called micelles that trap the cholesterol and keep it dissolved in the liquid.
Like mixing oil and water with soap.
Exactly. But during pregnancy, two major hormonal shifts occur. First, estrogen levels skyrocket. Estrogen actively stimulates the liver to secrete vastly more cholesterol into the bile.
Suddenly, there is way too much oil for the dish soap to handle.
Exactly. The bile becomes supersaturated.
So the cholesterol starts crystallizing.
Yes. But to form a stone, those microscopic crystals need time to clump together, a process called nucleation. This is where the second hormone, progesterone, comes in.
What does progesterone do?
Well, progesterone's job during pregnancy is to relax smooth muscle tissue to prevent premature uterine contractions. But the gallbladder is also made of smooth muscle.
Oh no. So the progesterone paralyzes the gallbladder?
It acts as a heady sedative. The gallbladder becomes sluggish. It doesn't squeeze efficiently when you eat. So now you have a stagnant pool of hyperconcentrated cholesterol-loaded bile just sitting there in a warm sac for months.
Wow. It just brews.
Right. The crystals precipitate, clump together, and slowly build into physical, pebble-like stones. The very hormones required to sustain human life create the ultimate chemical laboratory for stone formation.
That is wild. And what about the fat part of the mnemonic? Does having more adipose tissue, more body fat, just mean you have more cholesterol floating around in general?
It goes deeper than that. Adipose tissue is highly biologically active. Being obese or overweight actively increases the activity of an enzyme in the liver called HMG-CoA reductase.
That's a mouthful.
It is, but it's the master control switch for cholesterol synthesis. So the liver is chemically driven to pump out massive amounts of cholesterol into the bile, completely overwhelming those bile salts.
And age, the 40 factor, compounds all of this.
Yeah, because as we age, our liver naturally secretes more cholesterol and less of the protective bile salts.
And the masterclass also mentions specific genetics. People of Scandinavian descent, Pima Indians, and Hispanic populations have massive rates of gallstones.
The genetics are fascinating. For example, in the Pima Indian population, there are specific mutations in genes called ABCG5 and ABCG8.
What do those genes do?
They act like tiny molecular pumps in the liver, whose sole job is to pump cholesterol into the bile ducts. If those genetic pumps are hyperactive, they will saturate the bile with cholesterol from a very young age, completely independent of the person's diet or weight.
Now, the text makes a vital distinction here. It says that 90% of cholecystitis cases are calculous, meaning they're caused by these physical cholesterol or pigment stones blocking the exit,
Right.
but 10% are acalculous, meaning no stones at all. How do you destroy a gallbladder without a stone?
Acalculous cholecystitis is a disease of extreme physiological stress. We don't see this in healthy 40-year-old school teachers.
Where do we see it in?
We see this in elderly men with severe cardiovascular disease, trauma victims who have just survived massive car crashes, burn victims, or critically ill patients in the ICU.
People who are already fighting for their lives.
Yes, especially those on ventilators and being fed exclusively through their veins. Total parenteral nutrition, or TPN.
If there's no rock blocking the tube, why does the organ fail?
It's a failure of the feedback loop. When you eat food, specifically fat, your stomach releases a hormone called CCK, which acts as a messenger.
Okay, messenger hormones.
It travels to the gallbladder and screams, "Squeeze!" But if a patient is in a coma or only receiving IV nutrition, they aren't eating. The stomach never releases CCK. The gallbladder is never told to empty.
It's just sitting there waiting for a signal that never comes.
And while it waits, its walls are still doing their background job absorbing water out of the bile to concentrate it. Days turn into weeks. The bile becomes a thick, hyper-concentrated, incredibly toxic tar called biliary sludge.
Biliary sludge. That sounds awful.
It is. Because these patients are usually in shock, with low blood pressure, the tiny blood vessels feeding the gallbladder start to shut down.
So it's losing its blood supply.
Right. The toxic tar begins to chemically burn the mucosal lining of the gallbladder from the inside out, while the lack of blood flow kills the tissue from the outside in.
So the organ just rots from neglect.
It is a devastating complication. It often carries a much higher mortality rate simply because the patient is already on life support. But whether the disease is a calculus from toxic sludge or calculus from a physical rock, the physics of the organ's failure are identical.
Okay, with that grim, terrifying picture painted, let's step off the textbook pages and into the virtual clinic.
Let's do it.
We are opening up case 1 from the AI surgical tutor simulation in the masterclass. Our patient is Mrs. Lakshmi.
Let's review the chart. Mrs. Lakshmi is a 45-year-old school teacher. She arrives at your outpatient clinic reporting 6 months of episodic right upper quadrant pain.
The AI is very meticulous with her history. She says her pain consistently occurs about 30 to 60 minutes after she eats meals. Specifically, heavy fatty meals like a rich curry or fried food.
Very classic timing.
And the pain lasts for about an hour or two, feels like a tight band, and radiates to her right shoulder blade.
Notice that timeline. It's not an immediate pain like a stomach ulcer when food hits acid. It takes 30 to 60 minutes.
Why that specific window?
That's exactly how long it takes for the fat in her stomach to trigger the release of that CCK hormone we talked about, travel through the bloodstream, and force the gallbladder to contract.
So the meal pulls the trigger.
When it contracts, it pushes a gallstone straight into the narrow bottleneck of the cystic duct.
And just as important as the pain is what she doesn't have. The AI highlights that she has no jaundice, no fever, no chills. Between these painful episodes, she goes back to feeling perfectly fine.
Right, she's not systemically ill.
Her vital signs are stable, and when the virtual surgeon presses on her abdomen, it is completely soft.
The AI tutor then prompts the surgical student. What is this first-line investigation? The gold standard here, universally, is a right upper quadrant ultrasound.
I want to pause here. Why ultrasound? Why not an X-ray or a CT scan? I mean, we use CT scans for everything else in the abdomen.
It's a quirk of chemistry. X-rays and CT scans rely on density, mostly calcium, to show up bright white.
Like bones.
Right.
Yeah.
But remember, the vast majority of gallstones are made of pure crystallized cholesterol. Cholesterol is fat. It doesn't block X-rays well. Up to 85% of gallstones are completely invisible on a standard X-ray. You would just see a black void.
But sound waves act differently.
Entirely differently. An ultrasound machine uses piezoelectric crystals to fire high-frequency sound waves into the body. When those sound waves hit a dense, solid cholesterol stone, they can't pass through it.
They bounce off.
They violently bounce back to the probe. On the monitor, the stones show up as bright, hyperechoic white spots.
And then there's the shadow, right?
Yes. Because no sound waves can pass through the stone to illuminate the tissue behind it, there is a literal black shadow cast underneath every single stone called posterior acoustic shadowing.
It's like standing under an umbrella in the rain.
Exactly. It is definitive, irrefutable proof of a solid object. Plus, ultrasound is cheap, involves zero harmful radiation, and can be done right at the bedside.
The simulation provides Mrs. Lakshmi's ultrasound report. It reads, quote, multiple hyperechoic foci with posterior acoustic shadowing within a normally distended gallbladder. It also notes her gallbladder wall thickness is 3 millimeters.
Which is perfectly healthy.
Yeah.
Anything under 3 to 4 millimeters means the wall is thin, pliable, and not swollen with inflammation.
Her common bile duct measures 4 millimeters, again, well under the 6 to 7 millimeter danger zone, which proves no stones have escaped to block the main plumbing.
That's a huge relief.
There is no fluid leaking around the organ, and crucially, she has a negative sonographic Murphy's sign.
That last detail is vital. A sonographic Murphy's sign is a brilliant test.
How does it work?
The technician takes the hard plastic ultrasound probe, presses it directly into the patient's abdomen right over the gallbladder, and pushes down. If the gallbladder is acutely infected and rotting, that pressure will cause the patient to wince, gasp, or scream. If Mrs. Lakshmi doesn't flinch, her gallbladder is irritated, but it is not acutely infected.
So the AI confirms the diagnosis, symptomatic cholelithiasis, biliary colic. Here's where it gets really interesting. The simulation immediately asks the student for the indications for a laparoscopic cholecystectomy, removing the gallbladder entirely.
Right, the surgical option.
But I'm looking at Mrs. Lakshmi's chart and I'm just confused. Her vitals are completely normal. Her liver enzymes are fine. She is currently sitting in the clinic in zero pain. Why are we talking about amputating an organ?
It seems extreme, I know.
Why not just put her on a strict low-fat diet? Or better yet, if we can use sound waves to see the stones, why not just turn up the power and use sound waves to shatter the stones like we do for kidney stones?
You're suggesting extracorporeal shockwave lithotripsy. It's a very logical thought, and we absolutely use it to obliterate kidney stones, but using it on a gallbladder is a recipe for disaster.
Why? A rock is a rock.
It's about the exit routes. When you shatter a kidney stone into tiny shards of gravel, those shards travel down the ureter into the bladder and out through the urethra.
Right. It passes.
It hurts, But the plumbing is relatively wide and straight.
Mm.
If you shatter a gallstone into a dozen sharp shards, those pieces don't leave the body. They drop down the cystic duct and funnel straight into the common bile duct.
At the main pipe.
Yes, and at the bottom of the common bile duct is a tiny muscular valve called the sphincter of Oddi, right where the bile duct meets the pancreas.
And it gets stuck.
If a jagged shard of a shattered gallstone gets stuck in that sphincter, you don't just have a gallbladder problem anymore. The bile backs up into the liver, causing severe jaundice and cholangitis. Even worse, the digestive juices from the pancreas back up into the pancreas itself.
Triggering acute pancreatitis?
Exactly. You turn a highly manageable, localized pain into a systemic, potentially fatal multi-organ failure. We do not shatter gallstones.
Okay, so lithotripsy is out. But still, why operate right now? She's fine today. Why not wait?
If we connect this to the bigger picture, it is all about mitigating future catastrophe. Yes, Mrs. Lakshmi is fine at this very second, but she has a bag of rocks inside her that are actively trying to block the exit every time she eats.
A ticking time bomb.
The masterclass data provides the cold, hard math. Leaving symptomatic gallstones in place carries a 20% risk of developing acute cholecystitis over the next decade. 1 in 5 patients will eventually hit the tipping point where the stone gets stuck and doesn't fall back down.
And as you just mentioned, there's the risk of those stones slipping out entirely, causing jaundice or pancreatitis.
Or, over decades, the chronic, repetitive scraping of those stones against the delicate mucosal lining of the gallbladder causes deep cellular damage.
Which leads to cancer.
Yes, it's a primary driver of gallbladder carcinoma, a cancer that is exceptionally aggressive and difficult to treat. By offering her an elective surgery now, you are curing the disease in a highly controlled, safe environment, rather than waiting for her to arrive by ambulance at 3 a.m. with a rotting organ.
Elective surgery is always safer than emergency surgery. But let's play the tape forward. Let's look at the alternate reality in Professor Selvaraj's algorithm.
Let's look at the worst-case scenario.
What happens if Mrs. Lakshmi is terrified of surgery? She declines the operation, she tries to manage it with diet, but one night, she eats a heavy meal, the gallbladder squeezes, the stone slams into the cystic duct, and it stays there.
It gets wedged so tightly it completely seals the exit. She crosses the line into acute cholecystitis.
What does that look like clinically?
The moment that stone locks into place permanently, her clinical picture violently shifts. The pain doesn't fade after an hour. It becomes relentless, burning, persistent pain lasting far beyond the 3-hour mark.
She can't ignore it anymore.
She begins to experience anorexia, a complete revulsion to food. Severe nausea and vomiting set in, and most importantly, she develops a fever.
Because the body recognizes that the organ is dying.
Precisely. Remember, the gallbladder is still producing mucus. It blows up like a water balloon. The extreme internal pressure squashes the tiny veins and arteries in the wall of the gallbladder.
So it's choking itself.
The tissue starts choking to death from a lack of oxygen mucosal ischemia. The immune system detects this necrotic, dying tissue and unleashes a massive inflammatory response, flooding the area with white blood cells.
The physical exam changes dramatically at this stage, too. The AI notes the patient would develop, quote, guarding, and a positive clinical Murphy's sign.
Guarding is fascinating. It is an involuntary primitive reflex. The patient's brain knows the gallbladder is inflamed and fragile.
Like it's trying to protect it.
Exactly. If you try to press on their abdomen, their abdominal muscles will violently clench and lock up, creating a rigid, muscular shield to physically block your hand from touching the dying organ. They cannot control it.
And the clinical Murphy's sign, how is that different from the ultrasound version?
It relies on the physics of respiration. The doctor places their hand firmly deep under the right rib cage, right where the gallbladder lives. Then they ask the patient to take a deep, massive breath in.
And that pushes things around.
As the lungs expand with air, the diaphragm is forced downward. The diaphragm pushes the liver downward, and the inflamed, swollen gallbladder is driven directly into the doctor's waiting fingers.
So the parietal peritoneum, the incredibly sensitive inner lining of the abdominal wall, hits the hot, inflamed organ.
And the sudden spike of agony is so intense that the patient's brain will instantly override their breathing reflex. They will gasp and suddenly stop breathing mid-inhalation.
Just a sharp halt.
That involuntary inspiratory catch is a positive Murphy sign. It is a hallmark of acute cholecystitis.
If she hits the stage, the AI algorithm becomes militant about timing. The rules are absolute. It dictates that if a patient presents to the emergency room within 3 days, 72 hours of symptom onset, they get rushed to the operating room for an urgent cholecystectomy.
Get it out immediately.
But if they stagger into the ER on day 4, the protocol completely flips. Surgery is canceled, you put them on IV antibiotics, give them supportive fluids, wait for the inflammation to cool down, and then you send them home and schedule a delayed surgery for 45 days later.
It's a massive pivot in strategy.
Why the arbitrary 3-day rule? Why does the clock strike midnight at 72 hours, making surgery suddenly too dangerous?
It isn't arbitrary at all. It perfectly mirrors the biological timeline of severe inflammation. Think of inflammation as a massive, chaotic construction zone.
Okay.
In the first 72 hours, the body is rushing fluids and white blood cells to the gallbladder. The organ is swollen and angry, but the architectural boundaries, the fascial planes that separate the gallbladder from the liver and the blood vessels, are still intact.
So you can still see where everything is.
A skilled surgeon can still see the lines and dissect the organ out safely.
But on day 4...
On day 4, the construction site descends into pure anarchy. The tissues become incredibly friable. They lose their structural integrity.
Friable meaning delicate.
If a surgeon gently grasps the gallbladder with metal forceps, the tissue will literally crumble and tear like wet tissue paper. Simultaneously, the body triggers angiogenesis, the rapid growth of thousands of tiny, fragile new blood vessels to help fight the infection.
So the entire area becomes hypervascularized.
It bleeds profusely at the slightest touch.
And what about the surrounding organs? Does the body just let the gallbladder rot in isolation?
No, the body is terrified. The gallbladder is going to burst and spill infected bile into the entire abdominal cavity, which would cause fatal peritonitis.
So it calls in reinforcement.
Yes. The body deploys its natural band-aid, the omentum. The omentum is a large apron of fatty tissue that hangs over the intestines. It physically migrates up to the right upper quadrant and wraps itself around the dying gallbladder, sealing it off.
Wow, it literally moves to cover it.
The small intestine might adhere to it as well.
It's trying to quarantine the threat.
Yes. But to do that, it essentially superglues all these delicate organs together into one massive, rock-hard, bleeding, inflamed mass. If a surgeon tries to operate in that hot phase, they can't tell where the gallbladder ends and the main bile duct begins.
So they're just cutting blind.
The risk of accidentally severing a major artery or cutting the common bile duct skyrockets exponentially. It is incredibly dangerous.
So the 45-day wait isn't laziness, it's a tactical retreat.
Exactly. You give the patient antibiotics to kill any bacteria, and you wait 6 weeks. That gives the immune system time to stand down, the hypervascularity to recede, and the superglue to dissolve. 6 weeks later, the anatomy returns to a predictable, dissectable state.
But what if they never get treatment at all? They live far from a hospital or they just try to tough it out. The complication pathways in the masterclass are the stuff of nightmares.
They are horrific.
It mentions a mucocele, where the organ, unable to empty bile, just keeps secreting clear mucus until it swells to the size of a water balloon, or an empyema.
An empyema is horrifying. The stagnant bile becomes deeply infected with bacteria like E. coli or Klebsiella. The gallbladder literally transforms into a pressurized sac of thick white pus.
Good Lord.
If the pressure continues to build, the blood supply is completely choked off, leading to gangrene. The tissue turns black and rots, and eventually the balloon pops. Perforation.
Spilling that infected pus directly into the abdomen, creating a localized subhepatic abscess, or worse, widespread sepsis.
But sometimes, the body's quarantine mechanisms are so aggressive they create an entirely different kind of disaster.
How so?
Let's say the gallbladder is intensely inflamed and glued directly to the duodenum, which is the very first part of the small intestine. The immense, localized pressure of the gallstone pressing against the wall of the gallbladder slowly grinds away the tissue, eroding a hole straight through the gallbladder wall and directly into the adjacent intestine.
It literally wears a hole between the two organs, a fistula.
A cholecystoduodenal fistula. The body essentially creates an illegal shortcut. The massive golf ball-sized gallstone drops out of the rotting gallbladder, bypasses the bile ducts entirely, and falls directly into the small intestine.
Well, wait, isn't that a good thing? The stone is out of the gallbladder. Won't the patient just pass the stone naturally now?
That's the trap. The human small intestine is about 20 feet long, and it gets narrower as it goes. That massive stone travels down the bowel until it reaches the ileocecal valve, the narrowest point right before the large intestine.
And it gets stuck.
It gets stuck like a cork in a wine bottle. This causes a complete mechanical bowel obstruction, a condition called gallstone ileus.
What happens then?
The patient stops passing gas, their abdomen distends massively, and they begin vomiting fecal matter.
Oh my God, throwing up feces.
Yes, it requires an emergency open abdominal surgery to cut the intestine open and extract the rock.
The human body's capacity for complex, cascading plumbing failures is just astonishing.
It really is.
The source also mentions Maridzi syndrome, where the stone doesn't even have to leave the gallbladder to cause chaos.
Maridzi syndrome is a cruel anatomical trick. The siftic duct runs parallel to the main common bile duct for a short distance. If a truly massive stone gets wedged into the neck of the gallbladder, it physically bulges outward.
Pressing against the main pipe.
Right. It presses so hard against the outside of the adjacent common bile duct that it pinches the main pipe completely shut, like stepping on a garden hose. The patient develops profound jaundice and liver failure, all from a stone that technically never left the gallbladder.
Which brings us right back to the brilliance of Professor Selvaraj's core thesis. Get the gallbladder out before the superglue, the gangrene, and the fistulas ever happen.
Proactive surgery saves lives.
Let's jump forward in the AI simulation to part 2. Mrs. Lakshmi wisely agrees to the elective laparoscopic cholecystectomy. We are in the preoperative preparation phase. What needs to happen before she goes to sleep?
The AI prompts the surgeon for the necessary preoperative blood work and investigations. You need a complete blood count to check for hidden infections or anemia. You need a coagulation profile to ensure her blood clots normally.
Because you don't want an uncontrollable hemorrhage during surgery.
Exactly.
Yeah.
You order an ECG to check the electrical activity of heart, ensuring she can survive the physiological stress of general anesthesia. And crucially, liver function tests, or LFTs.
But we know her liver is fine. We have the ultrasound proving the stones are inside the gallbladder. Why test the liver enzymes today?
Because time has passed since that ultrasound. You must rule out occult cholelithiasis.
What does that mean?
You need absolute chemical proof that in the days or weeks between her ultrasound and today's surgery, a tiny millimeter-sized stone didn't secretly slip out of the gallbladder and quietly lodge itself in the common bile duct.
Checking for escapees.
If her LFTs, specifically her bilirubin or alkaline phosphatase, are elevated, it means the main train is blocked. That changes the entire surgical plan. You cannot just remove the gallbladder. You have to go in with an endoscope and clear the main duct first.
But the AI confirms her LFTs are perfectly normal. She is fully optimized for surgery. The doors to the operating room swing open. The setup described in the masterclass is a masterclass in spatial geometry and physics.
It is incredibly choreographed. She is placed under general anesthesia. She is positioned supine flat on her back.
Okay.
Her arms are carefully padded and tucked tightly to her sides, not splayed out on arm boards. This is to allow the surgeon and the assistant to stand right up against the edge of the operating table, minimizing the distance they have to reach.
The anesthesiologist drops a nasogastric tube down her throat into her stomach, and a urinary catheter goes into her bladder. Why are we running tubes into organs we aren't operating on?
It's about creating physical real estate. The abdomen is a finite, cramped box. If the stomach is full of gas from the anesthesia mask, or the bladder is full of urine, they expand like balloons, crowding the surgical field.
Taking up precious space.
By decompressing the stomach and draining the bladder, you shrink those organs down, pulling them out of the way. It gives the surgeon a vastly clearer view and completely eliminates the risk of accidentally stabbing a swollen stomach with a sharp surgical instrument.
Let's talk about getting those instruments inside. The transition from massive open incisions, cutting the patient from the breastbone to the belly button to laparoscopy, completely revolutionized surgery.
It changed everything.
But the text details the geometric precision of the port placement. They don't just randomly poke holes wherever they want. It's a highly standardized 4-port technique.
Yes, 4 very specific entry points. The sequence begins at the umbilicus, the belly button. The surgeon makes a small incision and inserts the primary 10 to 12 millimeter port. This is the camera port.
Got it.
But before the camera goes in, this port serves an even more critical function, establishing the pneumoperitoneum.
Inflating the belly with gas. How exactly does that work?
The surgeon connects a heavy tube to the umbilical port and pumps medical-grade carbon dioxide gas directly into the abdominal cavity.
Blowing it up like a balloon.
The gas literally lifts the abdominal wall, the muscles, and the skin up and away from the internal organs. They inflate the abdomen to a strict pressure, usually 12 to 15 millimeters of mercury.
What happens if they pump in too much pressure?
If the pressure goes too high, the gas compresses the inferior vena cava, the massive vein returning blood to the heart. the patient's blood pressure would crash instantly.
Oh, wow.
Furthermore, that pressurized gas pushes the diaphragm up into the chest cavity, making it incredibly difficult for the anesthesiologist's ventilator to expand the lungs. It's a delicate physiological balancing act. But when done correctly, it creates a hollow physical dome, a cavernous workspace inside the body.
Into that hollow dome, they insert the high-definition 4K camera. Suddenly, the surgeon is looking at the organs on a massive flat-screen monitor. Then come the working ports.
Next is the secondary 10 to 12 millimeter port, placed high up in the epigastric region, just below the sternum. This is the primary working port for the surgeon's right hand.
Right.
This is where the dissecting hooks, the tiny surgical scissors, and the heavy metal clip pliers will go in and out.
Then, two smaller 5 millimeter ports are placed along the right side of the ribcage. One on the white subcostal anterior axillary line. That's the port for the surgeon's left hand.
The surgeon slides a long, ratcheted grasper through that left-hand port, reaches deep into the abdomen, grabs the very top dome of the gallbladder, the fundus, and forcefully pushes it up and completely over the edge of the liver.
Like flipping a hood of a car.
Exactly. This flips the organ backward, exposing the critical plumbing underneath.
And the final 5 millimeter port placed on the right subcostal midclavicular line is for the surgical assistant. The assistant slides a grasper in, grabs the neck of the gallbladder, the infundibulum, and pulls it firmly down and out toward the patient's right hip.
That pull provides essential countertraction. You cannot cut tissue cleanly if it is slack. The tissue must be pulled taut, under tension, so the surgeon's dissecting tools can cleanly separate the anatomical planes.
It sounds like operating a multi-armed mechanical crane inside a tiny inflated balloon. It requires absolute spatial awareness. You've got 4 distinct rigid metal rods crossing paths, pivoting on the abdominal wall, all while the surgeon is staring straight ahead at a flat 2D monitor, totally disconnected from their own hands.
It is a phenomenal display of hand-eye coordination. Laparoscopic surgery demands that surgeons retrain their brains.
Because they can't feel anything.
Right. They lose complete stereoscopic vision. There is no true 3D depth perception on a flat monitor. They lose direct haptic feedback. They can't feel the pulse of an artery with their fingertips anymore. They can only feel the mechanical resistance of the tissue through the shaft of a 30-centimeter metal instrument.
So the risk of error is high.
Laparoscopy minimizes the trauma to the abdominal wall, meaning less pain and faster recovery. But we cannot forget that the internal risks, the massive life-threatening dangers of severing the wrong duct, remain identical, if not higher, than in open surgery.
And those internal risks bring us to the absolute crescendo of this deep dive, the core tenet of Professor Selvaraj's masterclass, the holy grail of biliary surgery.
The critical view of safety.
The framework explicitly states that before the surgeon is allowed to deploy a single metal clip, before they are allowed to cut a single piece of tissue, they must achieve and document this critical view of safety, or the CVS. It is described as non-negotiable.
It is the absolute bedrock of modern, safe gallbladder surgery. The CVS was developed by Dr. Steven Strasberg in the 1990s as a direct response to a horrifying spike in surgical accidents when laparoscopy first became popular.
What were they accidentally doing?
Cutting the main common bile duct. The CVS is designed to prevent that specific catastrophic event.
So how does a surgeon actually achieve this view? It's not just looking really closely. There are 3 mandatory physical criteria that must be met.
First, the surgeon uses blunt dissection, gently teasing and spreading the tissue, to clear all the fat and fibrous connective tissue out of the hepatocystic triangle, historically known as Kellow's triangle.
What's in that triangle?
It's the anatomical space bordered by the cystic duct, the common hepatic duct, and the inferior edge of the liver. This triangle is usually packed with dense, yellow fat and lymphatic tissue. The surgeon must meticulously strip all of it away.
Like bare it completely.
The space must be completely skeletonized. You need to be able to see completely through it, looking at the bare liver bed behind it.
I think of it like renovating a house. You can't just take a sledgehammer to a wall. You have to carefully strip off the drywall, remove the insulation, and expose the wooden studs so you can absolutely identify which beams are holding the roof up and which wires have live electricity running through them.
That is a perfect analogy. You have to strip the drywall. Criterion 2 requires the surgeon to look higher up. The lower 1/3 of the gallbladder body must be physically dissected and peeled off the liver bed, the cystic plate.
Why peel it off?
You have to prove that the organ you are holding is actually the gallbladder by separating it from its anchor.
And the third, and arguably most important, unbreakable rule.
Once the triangle is cleared of all fat and the base of the gallbladder is peeled off the liver, the surgeon must pause, look at the monitor, and visually confirm that only two structures are seen entering the gallbladder.
Only two.
The cystic duct, which carries the bile, and the cystic artery, which supplies the blood flow. If you see three structures entering the organ, stop. If the anatomy looks weird, stop.
If you see three, you have misidentified the anatomy.
Exactly. Only once the critical view of safety is definitively achieved, the surgeon can proceed. They slide a specialized tool down the epigastric port that fires titanium clips.
To pinch off the pipes?
Right. They place two clips on the patient's side of the cystic duct and one clip on the gallbladder side and use tiny scissors to cut between them. They repeat the exact same clipping and cutting for the cystic artery. The plumbing is now completely sealed and disconnected.
And then the messy part. Using an L-hook electrocautery tool.
Electrocautery is brilliant physics. The surgeon uses a tiny metal hook connected to an electrical generator. When the surgeon steps on a foot pedal, high-frequency alternating current flows through the hook.
It's basically a tiny lightsaber.
It acts like one. As the hook touches the connective tissue binding the gallbladder to the liver bed, the electrical current causes the water molecules inside the cells to vibrate so intensely that they instantly vaporize into steam.
Unzipping the tissue.
The tissue effectively unzips, while the sheet simultaneously seals any tiny bleeding blood vessels.
They carefully burn the entire gallbladder off the liver bed, and suddenly this rotting, stone-filled organ is just lying free inside the abdominal cavity.
The surgeon slides a specialized plastic retrieval bag down the umbilical port. It opens up like a tiny parachute inside the abdomen.
A little trash bag.
The surgeon uses their graspers to drop the gallbladder into the bag, pulls the drawstring tight so no infected bile or stones can spill, and forcefully yanks the entire bag out through the 12-millimeter incision at the belly button.
So what does this all mean? Why is the algorithm so militantly strict about the CVS? Why force surgeons to strip drywall and identify studs? What happens when a surgeon gets overconfident, skips the CVS, and just starts clipping what they assume is the right duct?
This raises an important question about the reality of human anatomy. We are not mass-produced cars built on an assembly line. The embryological development of the human biliary tree is notoriously chaotic.
How chaotic?
Up to 30% of human beings have significant anatomical anomalies in their bile ducts and blood vessels.
Anomalies? Like the wiring is literally different from person to person.
Completely different. Sometimes a patient has an incredibly short cystic duct, maybe just 1 or 2 millimeters long. So the gallbladder looks like it is fused directly to the side of the massive common bile duct.
That sounds dangerous.
It is. Sometimes the right hepatic artery, the massive blood vessel feeding the right side of the liver, takes a dangerous looping detour straight down into callous triangle before heading back up to the liver. Sometimes there are entirely extra, aberrant bile ducts draining straight from the liver into the gallbladder.
So if you memorize a textbook drawing and expect the patient to look exactly like the drawing, you are going to kill them.
And laparoscopy creates a specific deadly optical illusion. Remember, the assistant is forcefully pulling the neck of the gallbladder outwards. If the surgeon pulls too hard, they can literally tent the main common bile duct, pulling it up so violently that it bends into a sharp V shape.
Oh, no.
On a 2D monitor, that bent common bile duct looks perfectly parallel to the camera. It looks exactly like a normal, long cystic duct.
Oh, wow. So the camera lies to them.
It's an illusion of perspective.
Yeah.
If the surgeon doesn't perform the CVS, if they just blindly fire metal clips across that duct and cut it, they haven't cut the cystic duct. They have transected the main common bile duct.
The masterclass lists the grim statistics: a 0.5% risk of bile duct injury, a 1% risk of missed stones, and a 0.1% risk of catastrophic vascular injury, where they accidentally clip the portal vein or the main hepatic artery. If a surgeon falls for that optical illusion and clips the main bile duct, what happens to the patient?
It is a devastating, life-altering, and sometimes fatal complication. The patient wakes up, but their liver has no way to drain bile into the intestines anymore.
So it just backs up.
The bile backs up, destroying the liver. Or, if the clip falls off, liters of caustic, toxic bile leak freely into the abdominal cavity, causing catastrophic peritonitis.
How do you even fix that?
To fix it, the patient has to be rushed to a highly specialized tertiary care center for a massive, open abdominal reconstructive surgery called a hepatococystectomy.
That sounds intense.
A specialist literally cuts a piece of the patient's intestine and sews it directly to the microscopic stumps of the bile ducts high up in the liver just to recreate a makeshift drain.
The trauma of that is unimaginable.
Which is precisely why the critical view of safety is a forced cognitive checkpoint. It removes arrogance. It removes assumptions. It forces the surgeon to empirically prove the anatomy beyond a shadow of a doubt before committing to an irreversible cut.
It's a fascinating blend of elite mechanical skill and rigid, unyielding psychological discipline. And thankfully, in our AI simulation, the student successfully strips the drywall, achieves the CVS, clips the correct ducts, and removes Mrs. Lakshmi's gallbladder safely.
A textbook outcome.
The organ is in the bucket. The surgery is complete, but the masterclass doesn't stop there. We move into the final phase, closing up and the road to recovery.
There is a crucial final mechanical step before the anesthesiologist wakes the patient up. The surgeon removes the gas, deflating the abdomen. But they cannot just put a Band-Aid over those port sites.
Why not?
The algorithm mandates a fascial closure for any port site that is 10 millimeters or larger.
That would be the primary camera port at the belly button and the main right-hand working port in the epigastrium. What exactly is fascia, and why can't we just stitch the skin together and call it a day?
The skin is just a waterproof barrier. It has very little mechanical strength. The fascia is the dense, tough, fibrous sheet of connective tissue that wraps around your abdominal muscles.
It's like the structural drywall.
It is the structural integrity of your core. It holds your intestines inside your body. When the surgeon pushes a 12-millimeter metal rod through the fascia, they create a hole in the structural wall.
And if you just sew the skin over that hole,
The immense natural pressure inside the abdomen from coughing, standing, or sneezing will eventually force a loop of small intestine up through that unclosed hole in the fascia, trapping it just beneath the skin.
a hernia.
That is a port site hernia. The trapped intestine can lose its blood supply, strangulate, and die, requiring another emergency bowel surgery.
So the surgeon has to physically dive back into the incision, grab the edges of the thick white fascia, and use heavy, slow-dissolving sutures to permanently lash the structural wall back together under direct vision.
Only after the foundation is secured do they use surgical glue or incredibly fine stitches to close the cosmetic skin layer.
With the fascia tightly secured, Mrs. Lakshmi's post-operative course begins. And this is where the sheer miracle of laparoscopic surgery shines brightest. The masterclass notes that she will likely have a same-day discharge, or at most a 23-hour observation period in the hospital.
The physiological turnaround is astonishing. Because the abdominal muscles weren't sliced open with a scalpel, her body doesn't register the trauma as a massive injury.
It thinks it just got a few pokes.
She will wake up, and within hours, the nurses will offer her clear liquids. As soon as her stomach proves it can handle fluids without nausea, she can advance to a normal diet.
I just have to marvel at that timeline. It's science fiction. You have just been rendered completely unconscious with paralytic drugs, had your abdominal cavity pressurized with carbon dioxide gas, had 4 rigid metal rods plunged into your core, had an entire diseased organ electrically burned off the surface of your liver, bagged, and dragged bodily out through your belly button, and you are sitting up in bed, chatting and drinking apple juice 3 hours later.
It is the pinnacle of modern surgical technique. Her pain management is equally streamlined. Because the incisions are so small, she usually only requires simple oral analgesics and NSAIDs like ibuprofen or acetaminophen.
Just over-the-counter stuff.
The tiny Band-Aid incisions will sting and her shoulders might ache bizarrely.
Why would her shoulders hurt? We operated on her stomach.
It's a phantom pain caused by the carbon dioxide gas. Even after they deflate the abdomen, tiny pockets of CO2 remain trapped against the diaphragm.
And that causes shoulder pain.
The gas irritates the phrenic nerve, which supplies the diaphragm. Because of the way our nervous system develops in the womb, the brain misinterprets the distress signal from the diaphragm as a dull, aching pain in the tips of the shoulders. It usually resolves in a day or two as the body naturally absorbs the gas.
And getting back to her normal life, the simulation noted she's a 45-year-old school teacher.
Because she has a relatively sedentary, desk-type job, she is cleared to return to work in just 1 to 2 weeks.
That's fast.
If her job involved manual labor, say she was a construction worker or a warehouse employee, the timeline stretches to 3 to 4 weeks. There's one universal, strict rule across the board. Absolutely no heavy lifting, nothing over 10 or 15 pounds for 4 to 6 full weeks.
That's to protect those deep fascial closures we just talked about, right? So she doesn't accidentally pop a hernia while picking up a heavy stack of textbooks.
Precisely. The superficial skin seals and looks completely healed in 7 days, but the deep structural fascia is slow-healing tissue with poor blood supply. It takes a minimum of a month for those sutured edges to merge and regain their tensile strength.
It is genuinely amazing how strict adherence to these algorithms. The specific ultrasound criteria to prove the stones, the rigid 3-day rule for navigating acute inflammatory superglue, the precise geometric choreography of the multi-port entry, and the absolute unyielding mandate of the critical view of safety. How all of these codified, deeply physical rules take a disease that historically killed countless millions of people in agony and turns it into a highly predictable, manageable outpatient procedure.
It really highlights the immense value of the kind of structured, immersive education that Professor Selvaraj is championing with this masterclass.
It's just a world-class learning resource.
It strips away the guesswork. It takes the terrifying black box of the abdomen and illuminates it with protocol, physics, and profound anatomical respect.
We have covered so much ground today. We started at the microscopic level, unpacking the hormonal shifts, the overactive cholesterol pumps, and the fluid dynamics that cause a sluggish gallbladder to precipitate stones.
The genesis of the problem.
We mapped the exact clinical timelines that separate a temporary, painful colic spasm from a full-blown, gangrenous systemic emergency. And we walked, step by step, through the high-stakes optical illusions and the mandatory safety protocols of a laparoscopic cholecystectomy.
You've essentially completed a hyper-condensed foundational module of a surgical residency. You understand not just what the surgeon does, but exactly why they must do it.
But, as always on this show, we want to leave you with a final thought. A new physiological mystery that builds on everything we've just explored. We just spent an hour talking about how to safely, cleanly, and permanently remove the gallbladder from Mrs. Lakshmi's body. We bagged it, pulled it out through her umbilicus, and tossed it in the pathology bin. The crisis is averted.
The organ is gone.
But remember what we established at the very beginning. The gallbladder actually had a job. Its sole purpose was to act as a highly concentrated reservoir. It spent all day sucking water out of bile, making it incredibly potent, so that when Mrs. Lakshmi ate a greasy cheeseburger, it could squeeze and deliver a massive, powerful shot of biological dish soap directly into her intestines to dissolve that fat.
The ultimate degreaser.
Right. So my question for you to ponder is this. What happens to her digestion tomorrow, next month, or next year? The liver is still making bile, but the storage tank is gone. The liver is now just continuously, mindlessly dripping weak, unconcentrated, watery bile directly into her intestines 24 hours a day, constantly trickling down the plumbing, regardless of whether she is eating a massive fried meal or sleeping peacefully in her bed.
It's an entirely new plumbing dynamic.
How does the human body adapt to that? How does the microscopic sphincter of Audi rewire its own reflexes to handle a continuous leak? How does her digestive tract restructure its lipid absorption without its primary soap dispenser? And why aren't the millions of people walking around without gallbladders constantly malnourished from massive fat malabsorption?
That is a phenomenal question about physiological plasticity. The body's ability to seamlessly adapt to missing a fundamental organ, to instantly reprogram its digestive flow, is a testament to how endlessly beautifully resourceful human biology really is.
It truly is a marvel. Think about the hidden magic of that continuous drip the next time you eat a heavy meal. We want to thank you so much for joining us on this deep dive into the murky, high-stake waters of biliary surgery. Until next time, stay curious.